Hello and good evening and good day to everyone. Please let me know that you can hear me loud and clear. It's good to be back. It's our live event. It's 8 p.m. UK time, so it is definitely time to start our event. And we do have another special guest. As you can see, this is Dr. Robert Najdecki. And Dr. Robert, how are you feeling tonight?
Thank you very much, Caroline. I am fine and ready to present our webinar presentation.
I am very happy to hear that. Thank you so much for this, and thank you for joining our Stronger Together initiative, and of course for bringing this new also topic to us as well. And before we start, as you know, I just want to mention that we have another special guest from Greece. Thessaloniki this time, and I just also want to mention that Dr. Robert Najdecki is our partner and ambassador when it comes to Greece as a fertility destination of 2021. So thank you also for joining this initiative, and it's great to have you here. And I do see that you have mentioned the result, and I hope that you were able to hear Dr. Najdecki loud and clear. Please let me know, because this is the most important part. Okay, that would be great. And one more thing that I would like to mention, of course, that as you know, all those Stronger Together events have been brought to you thanks to our ambassadors and partners. So as always, I want to thank them for their support. There were plenty of those webinars already, and there are more events coming up. So definitely I want to make sure that they know that we appreciate their support. And as I've mentioned, we do have an interesting topic, which is FEI, a new approach in the therapy of implantation failure, aspiring to replace the traditional endometrial scratching. So we will start with Dr. Najdecki's presentation, and afterwards it will be time for your questions. So as always, put them in the chat section, and he will be more than happy to answer. I have no doubt here. And okay, that will be it from me. Dr. Robert, are you ready to begin?
Thank you very much, Caroline. Dear friends, ladies and gentlemen, it's a great pleasure and honor to be here using this dedicated digital platform and sharing our knowledge and research with you. I would like to express my sincere and congratulations to our egg donation friends for their commitment, faith, and the highest level of services provided to us and to all our patients. Please, okay. I'm really excited to introduce you to our new FEI method, Fundus Endometrial Incision, which aspires to replace the traditional endometrial scratching. Nowadays, despite of the scientific progress and advances in knowledge on human reproduction, the process of embryo implantation in the human uterus remains the most undiscovered part of the whole process of pregnancy. The fact that after using IRT techniques, only 25 until 30% of transferred embryos seem to be successfully implanting leaves a huge area to be investigated. The term implantation failure can be used to describe a patient who has never had increased level of HCG or without a clinically confirmed pregnancy via TVUS. Implantation failure can apply to patients undergoing assisted reproduction technology therapies and patients trying to conceive without any fertility treatment. Repeated implantation failure refers to when transferred embryos repeatedly fail to implant despite numerous attempts via assisted reproduction technology treatments. The implantation failure means no evidence of implantation, no detectable HCG production, or no visible formation of gestational sac despite detectable HCG, biochemical pregnancy. And recurrent implantation failure, it means that we have over 3 high-quality embryos transfers without any pregnancy. Successful implantation in an NR8 cycle is influenced by many complex factors: endometrial environment, intrauterine pathologies, endometrial thickness and pattern, endometrial decidualization, embryo quality and euploidity, embryo endometrium crosstalk and immune regulation, embryo endometrium synchrony, and embryo transfer technique and expertise, use of abdominal US guidance. The prevalence of congenital uterine anomalies has been reported to vary depending on the population and the diagnostic technique used. CUA has been shown to affect 4.3 until 7.7 until 6.7 of the general population, and from 3.4 until 8 in the infertile population, percentage in the infertile population. In women characterized as recurrent aborters, the figure has been reported to be 12 until 18.2%. Diagnosis of small uterine anatomical variations based on hysterosalpingographic imaging and 2D or 3D ultrasound scans is still difficult, uncertain, and often result in misdiagnosis. Even during hysteroscopy, the golden standard in uterine assessment, the diagnosis depends on operator experience and is therefore not always objective. Big congenital abnormalities, polyps, fibromas have been investigated, and their negative influence on the implantation process is statistically confirmed. Smaller anatomical variations can cause different degrees of uterine and endometrial dysfunction. Their influence on the implantation process is probably under-investigated, partially unknown, and underestimated. The first papers that remarked that small, not diagnosed anatomical abnormalities may play a significant role in implantation failure came with presentation of Venetis and Gribizis. The ESHRE-ESGA consensus on the classification of female genital tract congenital anomalies brought a new taxonomy system, helping to understand their implication in reproduction better. The new classification focuses also on the new small light categories. What we know already about endometrial scratching and implantation process? Several hypotheses supporting the positive effect on pregnancy rates. Over the past decade, endometrial scratching proposed to improve implantation, but the exact mechanism remains unclear. In the preceding cycle, improved clinical pregnancy and live birth rates in women with recurrent implantation failure, but not in unselected subfertile women undergoing IVF. Endometrial scratching or scratch injury is an intervention leading to enhanced endometrial receptivity by some mechanisms such as inflammatory reaction, better synchronization of the endometrium, inducing decidualization. There are a few types of scratching procedures, starting from using the curette with different catheters, Pipelle, Decor, or Novak curette, and finishing in hysteroscopic scratching. The techniques of hysteroscopic scratching are not sufficiently described in literature. There isn't any common consensus according to the technique and surgical tools. There is also a confusion about the timeline of the procedure. Some authors support follicular phase for the procedure, but some others think that the luteal phase is more appropriate. There is no common consensus, and the basic points are underpowered observational studies, many different techniques described in literature, usually performed using a soft plastic Pipelle endometrial biopsy catheter, differences in the number of times of the procedure, the degree of injury, variation in stimulation protocols, differences in timing, problematic control groups, usually in recurrent IF patients. Hysteroscopy allows reliable visual assessment of the cervical canal, uterine cavity for intrauterine adhesions, endometrial polyps, submucous fibromas, endometritis, or uterine malformations that could interfere with implantation. One of the most beneficial impacts of hysteroscopy is the correction of specific uterine cavity abnormalities when detected. Endometrial polyps, different degrees of septum or adhesions, are the most common findings in women with implantation failure in the literature. Hysteroscopy provides the opportunity to perform therapy in the same time, such as removing endometrial polyps or submucosal fibroids. Therefore, hysteroscopy is currently the only direct method for observing physiological and pathological changes of endometrium, as well as accurate scratching and treatment. Our proposed technique, named as Fundus endometrial scissor incision, is always performed in a cycle with OCP, 1 or 2 cycles prior to embryo transfer cycle, in the follicular phase of the cycle, from day 6 to day 10, on the line from the right opening of the fallopian tube to the left. Incision is continuing within the connective tissue until the appearance of the first vessels. And the benefits of this technique, always in the cycle prior to embryo transfer cycle, giving the stability and the time for inflammatory reaction in the same follicular part of the cycle, giving the stability of endometrial growth and thickness. The technique is detailedly described, allowing operators to perform the procedure in the same way every time. Performed under direct eye procedure in contraindication to all other blind scratching techniques. And let's watch a small video. Now we see the tube openings, and this is the scissor incision. The incision is in the line from the right openings to the left. And as you see, the incision is continuing within the connective tissue. This is the white area. And these small red signs are the blood small vessels which are occurring during the incision. It has been reported that the prevalence of minor intrauterine abnormalities identified by hysteroscopy is as high as 30 to 45% under normal transvaginal sonography, and abnormalities found by hysteroscopy are significantly higher in patients with previous assisted reproductive techniques failure. Two prospective and randomized controlled trials confirmed the value of hysteroscopy in women with RIF by demonstrating significantly increased clinical pregnancy rates. It has also been shown that the fertility-enhancing effect of hysteroscopy could be independent from the correction of intrauterine abnormalities. Hysteroscopy has been proposed to improve ART outcomes throughout the endometrial injury process, leading to embryo implantation. Here you have our presentation during the annual meeting 2020 of European Society of Human Reproduction. And you have the link here in blue words. And if somebody of you wants to write or to watch it deeper, this is the link. Please use it to see all the presentation. And this is our results from this presentation, this research. Actually, we have statistical significance with p-value of 0.015. And the better results of pregnancy in the group of hysteroscopy, it was about 73.7%, comparing to the non-hysteroscopic group with 57.34%. That's also the live birth rate was higher in the hysteroscopic group than in the non-hysteroscopic group. And this is about 56.2%. At Assisting Nature, we try to create an ideal personalized donation program. Using euploid blastocyst, we significantly increase pregnancy rate over 60% per embryo transfer. Using euploid blastocysts plus hysteroscopic fundus endometrial incision and plus enhancing endometrial receptivity by inducing decidualization through inflammatory reaction leads to real pregnancy. That we have euploid blastocyst transfer plus 10% in the pregnancy rate and plus hysteroscopic fundus endometrial incision plus another 10% in pregnancy rate, leading to the 70% rate after first ET in our program. And our conclusion: recurrent implantation failure is a complex problem with a wide variety of etiologies and mechanisms as well as treatment options. The recommendations for women with RIF vary depending on the source of their problem. Perhaps the best and the yet most complex answer is personalized medicine, a personal approach to each patient depending on her unique set of characteristics. Adding PGT and hysteroscopic fundus endometrial incision to egg donation cycles seems to be the state-of-the-art procedure, leading to the highest possible results. Endometrial preparation regimens that incorporate antithrombotic agents, immunosuppressive drugs, intralipid infusion could aid in the development of optimal endometrial environment for implantation. Thank you very much for your attention.
It's going to have you back at the center, and I'm very, very happy that you've been able to show us some new methods indeed as well. And well, now it will be time for your questions. So of course, if you have any in regards to this new method or any other questions that you might have, go ahead and type those in, and Dr. Najdecki will be happy to answer them for you. I know you can hear me with a little bit of an echo, so I will be showing the questions And I hope that it will be okay for you to simply read those, Dr. Najdecki, so we do not cause problems to our patients, okay? And let's have a look, okay? We are waiting for first question. Someone is typing, so we just need a minute to see it. And I will, of course, enable this for you. And just for those who haven't seen, I was able to send you a link, a direct link, so YouTube link where you can just watch the whole video as well. And again, we need to wait a bit as someone is again typing right here. Okay, next.
Yes.
So first question is right here. Can we
Okay.
use this method?
With our own eggs and not donor eggs? Absolutely. The method is for all purposes, and we are using the Fundus endometrial incision in every cases, preferring, of course, using this method after the one embryo transfer failure, that having the blastocyst or having the embryos in our patients after the one embryo transfer failure without hysteroscopy, we propose to our patients in every case before the second embryo transfer performing this hysteroscopical examination and this fundus incision, and it probably works in every case, not only in the case with acceptors. This is works in all cases of embryo transfer. That there is absolutely necessary before the second embryo transfer to use this technique.
And thank you for that. And let's have a look at the next.
Okay. Yes, Krishna. The difference is that as I focused, there is some steps. The first is, of course, the synchronization with your future embryo transfer cycle, that we are performing the hysteroscopy before the embryo transfer, and the embryo transfer must be performed in the next cycle or in the third cycle. That the influence of the fundus incision is the best. After 2 cycles, probably this mechanism are not working properly. That this is the first. The second is that this is technique which is very well performed, and we have very good view into the uterus, and it's not only to see, but it's the point is to perform this incision in the fundus. This is the reaction from the endometrium, and due to this reaction, we have these benefits. That it's it's impossible to compare this technique with every simple diagnostic hysteroscopy. This is an advanced technique and more sophisticated in this point. I tried to cooperate with some doctors in Great Britain, and following our steps and following our our advices. We performed some hysteroscopies in this way with quite good results, that after it, our transfers here in Thessaloniki were successful. That the technique is not very difficult, but it's focused on some points, that it must be performed in the follicle phase of the cycle from day 6 to day 10, and the embryo transfer must be performed in the second and in the third cycle, measuring from this point. Of course, it's also able to perform this technique and use this technique in the natural cycles, absolutely. But the better way is to use frozen embryos in this case, that collecting the eggs and collecting embryos in the natural cycle vitrified all this blastocysts, perform in the next cycle, perform this procedure, hysteroscopy procedure, and then in the third cycle try to transfer the embryos. This is the timeline. Of course, this technique is possible to be used in women with fibroids. Of course, it depends on the place which the fibroid is. In the fibroids are very close to the cavity. This is a general problem with embryo transfers. But if fibroids are endomuscular or in the uterus wall, there is no matter to connect the hysteroscopy with embryo transfer and not extracting these fibroids. Also, very small submucus, it's no problem. We also have 2-3 cases with extraction small submucous fibroids during the hysteroscopy. It depends on the operator experience. According to the platelet-rich plasma therapy, yes, we use it very, very rare. But if a case needs to use this technique, yes, we do it. Priscilla, do you know the increase in success rates with own eggs? Absolutely. It's the same, but in every case, I would like to say it again, that the better way and the better results are if we have the euploid embryos. That in every case that we are going through failure, IVF failure cycles, or failure with embryo transfer, there is a very smart step to use the PGTA technique and to be absolutely sure that you use the euploid embryos. If we have the euploid embryos, then the hysteroscopic procedure is very, very important, and we are talking about 10% and over. Generally, the technique is available everywhere. Everywhere who wants to perform this procedure is able to do it. that I'm sure that it will be very popular next year after our presentations and after our research. It will be more popular, and probably it will be available in every country. Krishna. Yes, of course, this is another issue that using hysteroscopy before the embryo transfer, we are absolutely sure for cervix opening, and it will be confirmed in the cycle, in the procedure with sedation, very comfortable for the patient, without any pain. And this is experience also for the operator, and for the operator in the case of embryo transfer, having all this information about the cervix and about the uterus, and helping him to perform the embryo transfer properly and without pain for the patient, of course. It's possible to have lower implantation rates after very difficult embryo transfer with difficulties in opening the cervix or into going through the cervix into the cavity. Yes, absolutely, it's possible, and we also prefer to use the hysteroscopy before. Generally, we haven't any problem until now using these techniques. Of course, it's depending on the operator experience. But using these modern hysteroscopies, which are very, very thin, and it's about 4 millimeters, that it's very, very rare case to have some complications during the hysteroscopy.
All right. Perfect. Thank you so much for those. Of course, I was showing them just so we will avoid this echo. So I hope that's okay. But we are waiting for some questions. Okay, someone again is typing and just commenting right here. This is definitely a very promising technique. I agree here for sure. And so, of course, if you have more questions, you know what to do. Just go ahead and type those in. If not, we will be slowly finishing. But I also want to mention that if you would like to get some more details from Dr. Najdecki and his whole team, you can just simply go to this site. And of course, there is an option for you to contact the clinic directly. And I know 100% sure that they will be happy to help you and provide you even more and more details. As always, you can imagine they also would need some more advice from you as well. And next question has shown right here.
Yes, in our unit, the cost is 1,200 euros per procedure. All the package.
All right, wonderful. Thank you so much for answering this one as well. And let's give it a minute. Just let us know if you have any questions left, of course. And before I let you go, Dr. Robert, thank you so much for bringing this. This is definitely interesting, and as many patients have mentioned, very promising. And well, before I let you go, is there anything else you would like to add?
No, thank you. I am in your disposal and ready to answer every question personally to our patients.
As always, Great to hear that, and thank you so much for that confirmation. And as you can see, of course, there are some comments for you. Thank you so much for the information, great presentation. Thank you. And I can only add that we're definitely happy that you are back and supporting our Stronger Together initiative. And I can apologize only for the echo that we're having tonight, but I hope you found it still okay to listen. I'm sure of it actually. And well, remember it has been recorded. So of course, if you would like to have a look at the video or just check it, just go ahead and do it. It will be uploaded on our website as always, my IVF Answers, and also on our YouTube channel. And of course, if you go to our Facebook or Instagram, you will know there are plenty more of the events coming up. And next week, again, on Friday, we will have a Greek expert. So I can only encourage you to join us on Friday. But as you know, we will be back on Monday and next days as well. Dr. Najdecki, it's always great pleasure to have you with us. Thank you so much. Everyone, have a lovely evening and weekend. And of course, hope to see you soon as well. Thank you,
Thank you
Dr.
very
Robert.
much. Thank you very
Good
much,
night.
and good luck to all. Bye
Fingers
bye.
crossed indeed. Thank you so much. Take care. Bye.